Good afternoon, ladies and gentlemen. Welcome to our very first webinar forum organized by the Malaysian Obstetric Medicine Society. We really apologize for the delay, and we hope we can assure you that there's going to be no problem after this. So we will end at 5:30 p.m. today. Now, our discussion today is on a colloquium on infective endocarditis in pregnancy. And before we go ahead with the discussion, let me introduce you to the panelists. First of all, we have Dr. Leong Chi Lun. Dr. Leong is the Senior Consultant of Infectious Disease working in Hospital Kuala Lumpur. He's also part of the committee helping to write the Malaysian CPG in prevention, diagnosis, and management of infective endocarditis. Welcome, Dr. Leong.
Thanks, Dr. Vicky.
Next up, we have Dr. Geetha Kandavelu. Dr. Geetha is the Senior Consultant in Paediatric Cardiology and Adult Congenital Heart Disease in IJN. And she is also the chairperson leading the committee in writing the Malaysian CPG for prevention, diagnosis, and management of infective endocarditis. Welcome, Dr. Geetha.
Thank you, Vicky. Very good afternoon, ladies and gentlemen.
And lastly, we have Dr. Monizuaran Ganeshan. Dr. Munis is the consultant obstetrician and gynecologist, and he's also the head of maternal fetal medicine unit in Hospital Tunku Aziza, formerly known as the Women and Children Hospital of HTAKL. Dr. Munis is also the founder and the current president of the Malaysian Obstetric Medicine Society. Welcome, Dr. Munis.
Good afternoon, everyone. Thank you, Dr. Vicky, for the kind introduction.
Right. Let's start our exciting discussion ahead. So we're going to talk about the colloquium on infective endocarditis in pregnancy. And our objective today is to discuss on SBE prophylaxis, a rather controversial topic in our current medical world. Then we will move on to discuss on the approach to infective endocarditis. And lastly, on surgical management in infective endocarditis, a field where most of us actually worried and fear to perform surgery, especially for the pregnant population. Right, so let's look at our first case scenario. I have a lady here. She's a 25-year-old, G1 para0 at 28 weeks. She has chronic rheumatic heart disease with severe mitral stenosis and had a mitral valve replacement done with a bioprosthetic valve at the age of 22. Now, in general, for such cases, do you routinely prescribe SBE prophylaxis? Dr. Geetha?
Thank you, Vicky. So we have a patient here with a mitral valve prosthesis, bioprosthetic. And there are two aspects of SBE prophylaxis that we need to discuss. And like earlier mentioned, this is a controversial area. The first would be in terms of, do we give SBE prophylaxis when she's undergoing a normal vaginal delivery? So based on the most recent 2018 ESC guidelines on pregnancy and heart disease, I think they have clearly stated that there's not enough evidence to show that if it's a normal, uneventful vaginal delivery, there is increased risk of infective endocarditis. And therefore, the guidelines do not recommend routine use of antibiotics in this particular group of patients. What is, I think, more important is the management of prevention, so good infection control practices, prevention of puerperal sepsis, and then if the patient is unwell, to diagnose early and to treat early. So that again is something that we practice, so we do not give routine antibiotic prophylaxis for vaginal delivery, but I do appreciate that it's a controversial area. Some may have different practices. The second area to discuss is the role of SBE prophylaxis when the patient undergoes a dental procedure. So you all have gone through the NICE guidelines when they said no antibiotic prophylaxis recommended. Then HA and ESC came out in 2018 and say for high-risk patients there is a role. And here high-risk patients for cardiac are anyone like this patient with a prosthetic valve. And again, anyone with prosthetic material, so all the conduits, the shunts, the devices, anyone with cardiac implantable electronic device, your pacemaker. Then you have all the congenital heart patients, mainly those are cynos, those who have unrepaired or palliated. And then they also talk about post-surgery. So if you've repaired somebody and you have done surgery, you've repaired the shunt, but within the first 6 months post-closure, you still want antibiotic prophylaxis because of endothelialization. And they've also added on if the patient is a post-transplant patient and has got valvular impairment or dysfunction, you want to consider. And again, what type of dental procedure, right? So it has been invasive where there's gingival break or intervention around the periapical. And native valves are again a controversial area. So when you have a native valve patient who has mitral stenosis or mitral regurgitation, then it becomes controversial whether you need antibiotic prophylaxis or not. So, so general guidelines don't recommend for native valves, but our guidelines, we have included severe rheumatic valve disease because of our current environment and the oral hygiene. So the choice of antibiotics, again, I'll leave it to Leong to discuss. And the whole controversy of why they came up with this, because they're worried about antibiotic resistance, right, Leong? Yeah. So maybe you want to share about the choice and this controversy about antibiotic resistance.
Okay, yeah, I think, Dr. Leong, you can...
Thanks, Dr. Geetha. Dr. Geetha has illustrated the controversy. When is it really need antibiotic prophylaxis and when not? As an infectious disease physician, I know we are more concerned about widespread use of antibiotic has created a lot of resistance, and we have less and less antibiotic to use if an organism become more and more resistant if we use antibiotic broadly. I know we are being trained to be safe doctors. We do not want complication happen. So a lot of time, I know Dr. Geetha already mentioned all the who are the patient required, who are the patient not required antibiotic. But sometimes people just give for everyone. But once is want to play safe. So have to remember what Dr. Geetha has mentioned. If you want to play safe, also remember to stop, not to prolong it after you give prophylaxis. Well, I see a lot of patients, even after that, play safe, you can continue and forgot to stop it. As for mainly, for all the antibiotic of choice that is being written down, amoxicillin, all that are actually for dental procedure. And coming to a patient who requires surgery, is stated in our guideline that any procedure where you require, let's say a surgical procedure requires surgical prophylaxis, let's say either caesarean section or any abdominal surgery or any cardiac surgery or anything, you already has an antibiotic guideline for that particular choice of antibiotic for that guideline, and we know that this antibiotic choice already more than enough to cover for bacterial endocarditis. So we did not need to add on anything. Just follow the surgical guideline. I leave it. Dr. Munis will say that caesarean section, what are the recommended prophylaxis, and we just use the same antibiotic.
Thank you, Dr. Geetha and Dr. Leong. I think it has been a conventional practice that patients coming for vaginal deliveries are given 2 antibiotics in obstetrics, and that is what I was trained as a medical officer, ampicillin and gentamicin. But I think, Dr. Geetha, you have highlighted who needs antibiotics. In fact, they looked into the risk of infection and the risk of anaphylaxis, and they realized that the risk of anaphylaxis was far higher than the risk of infective endocarditis per se. And broad spectrum antibiotics also sometimes causes worsening of gram-negative sepsis in the baby. So in our aim of causing good, we actually end up causing more harm. Now, if patients require caesarean section, the recommendation is a broad spectrum antibiotics. It can be cefuroxime or second generation cephalosporin. And like what Dr. Leong highlighted, that alone is sufficient, both for the caesarean section and to prevent the small risk of infective endocarditis. But yet again, vaginal delivery or genitourinary abdominal procedures, you don't really need to cover. So the current standard protocol, perhaps we need to change, adapt, and don't have to cover intrapartum.
Yeah, I think the most important thing is maintain good infection control practices and also good oral hygiene. So we recommend all patients with all these high-risk cardiac conditions to see the dentist regularly and practice day-to-day daily good oral hygiene. I think that's the most important message.
Dr. Leong, I'd like to highlight about this group of patients who have got penicillin allergy. Now, some people, the recommendations in UK is to use vancomycin. There's some newer studies that suggest azithromycin. What are your thoughts about clindamycin, vancomycin, or azithromycin?
Yeah, I will prefer, if let's say a really allergy to penicillin, I will say that using clindamycin will be good enough. Even, people worry about third generation cephalosporin. In the hospital setting, in fact, cross-reactivity may not be happening, as I think it's quite safe to use even third generation like or your cephalosporin like cefazolin. But if you are worried of that, then clindamycin will be a good prophylaxis. Vancomycin is also another alternative, but the downside is it causes renal toxicity. Azithromycin, I personally will not use because it's actually not bactericidal, number one, and second, also I will reserve it for. It's also one of our choice for NDTB and all that. I'm not that comfortable using azithromycin.
Okay, all right. So, anything else to add on SBE prophylaxis? Right, good. So I can roughly summarize that. So SBE prophylaxis is not routinely given, right? It's only given to some specific high-risk group, yeah? And specifically for our pregnant ladies, we now do not prescribe SBE prophylaxis for patients going through vaginal delivery, whereas for cesarean section, it's just our routine antibiotic prophylaxis for a cesarean section for any patient who's going through that procedure. Right, okay. So thank you to our panelists. So next up, we'll be talking about another more exciting case here with regards to infective endocarditis. Yeah. So we have a 33-year-old lady, Para 2. Now she's postpartum day 8 after a spontaneous vaginal delivery. She's got underlying comorbid, which includes gestational hypertension during the pregnancy. She's an active smoker. Her BMI is 37. Now, she presented to the emergency department with a history of fever for 2 days and sudden onset of bilateral visual loss. She also had incoherent speech. Now, I would like to ask Dr. Munis. Now, this is a postpartum patient. What is your approach for puerperal pyrexia, especially in this current COVID era? We are also COVID-driven. Are we missing something else here?
So thank you, Dr. Vicky. Puerperal sepsis is a term which is currently being advocated. I think in the last 2.5 years, we have been too COVID-centric, be it only thinking about COVID or ruling out COVID. So I think the principle is to be holistic. Traditionally, people used to think that puerperal sepsis is purely related to the genital tract. But the World Health Organization has changed that. So it includes infections of the genital tract and non-genital tract infections. So the leading infection among pregnant mothers in the postpartum is group A Streptococcus. So group B is the villain for babies, and group A is for the mothers. So a lady who's in the postpartum, who has got fever, I think we have to appreciate that itself is an obstetric and a medical emergency. I think we need to use the surviving sepsis care bundle. So escalate care, blood cultures within the first 3 hours, lactates. I think lactate is a simple tool marker of tissue hypoperfusion. Above 2, be worried. Above 4, she should be in ICU. Broad spectrum antibiotics. Now, antibiotics which obstetricians love is cephalosporin and metronidazole. I think that should not be at a spinal level, but at an individualized level. And then, is she in shock or is she not in shock? The vasopressors are recommended. So if she's in shock, the recommendation is crystalloids, 30 mils per kilo. And if despite resuscitation, if a mean arterial pressure is below 65, she will need vasopressors. And then look for a cause. Is it the uterus? Is it the genital tract? Is it the urinary infection? Is it the breast, which is sometimes missed as mastitis? Is it the lung? Is it the calf? It's good to be holistic. And then she has to be monitored in a high dependency ward using the early obstetric scoring chart. So don't always think it is endometritis. Don't always give cefuroxime and flagyl, but it's important to be holistic.
Okay, thank you very much, Dr. Munis. Sorry, panelists, I think you need to remember to switch on your mic, otherwise the audience can't hear you. Right. So next, what about Dr. Leong? If this patient says she comes in with a prolonged fever, what will be the approach for a PUO then?
Yeah. Okay, we go a little bit aware of this scenario first.
Right, sure.
On the topic of endocarditis, they usually presented with prolonged fever. So if such patient presented with prolonged fever, I see a lot of us clinicians love to feel like, as Dr. Munis already mentioned, the first line of antibiotic as purpura sepsis. Let's say he got prolonged fever. Dr. Munis already recommend cephalosporin or something. What I see our doctors do is this cephalosporin or whatever ceftriaxone being given probably is not good enough. So after 5 days, patients have been on antibiotic. Result culture still negative. If culture positive, people will tend to switch. Most of the time, if we forgot to take blood culture at the very first time in ED because of surviving sepsis campaign, give antibiotic first. There is no blood culture bottle in ED. Then after that, go up to the ward, send blood culture negative. Then this antibiotic is not working. What next? To escalate antibiotic. I feel that is not the way to go because sometimes when patient having prolonged fever, we need to also investigate why the patient having prolonged fever. So not that, ceftriaxone not working, then go to tazocine. Tazocine not working, go to meropenem. Meropenem not working, add antifungal linezolid. That's not a good habit that we are practicing. So we should think about what are the causes. So usually we'll go back to basic medicine. If the patient fever not respond, then we should also look back whether this patient has chronic infection such as TB, whether this patient has is a lady, whether he has underlying autoimmune disease like SLE, or whether this patient has malignancy. Sometimes lymphoma will be very mimic TB. We should think broad about this. At the same time, before you escalate antibiotic, we should be thinking broad and at the same time send more investigation, do another blood culture, and then we try our best to be a dictator, trying to investigate more what are the causes of this prolonged fever rather than escalating antibiotic.
Now, I want to ask you something. Sometimes, is there a role to maybe stop the antibiotic because you have just escalating without a culture? Is there a role that you stop for like maybe 48 to 72 hours, reculture back again, and then start prophylaxis? So at least, hopefully, you might be able to get a positive culture. Because nowadays, we get a lot of culture negative infective endocarditis patients because they've already seen others and have had treatment done, maybe incomplete antibiotic treatment. So is there a role?
Yeah, I totally agree there is a role, especially the patient is stable. Some of the patients are actually not in septicemic shock. Of course, in septicemic shock,
It's different.
It's different story. If the patient is not in septicemic shock, patient is clinically stable, we should be thinking about stopping the antibiotic and then reculture back. We will be more likely to get a pathogen, and then from what pathogen we can have better chance of predicting where is a source of infection.
Can I just add one other culture as an obstetrician? People often always talk about blood culture, but if the patient presents with preterm labor or chorioamnionitis, I think one important culture is the placental tissue culture. You'll be able to find the organism better as compared to a high vaginal swab or a low vaginal swab. So the placenta often tells the story.
Interesting.
Okay, interesting. Yeah. So now our patient actually, because of her neurological impairment, the bilateral visual loss, and also the incoherent speech, so the emergency team actually went ahead and performed a CT brain for her. So this is the CT brain image, and CT brain shows multifocal subacute bilateral posterior circulation and left anterior circulation infarcts with punctuate hemorrhage, possible hemorrhagic transformation of the infarct. So at this point of time, Dr. Leong, being the ID person, what would be your preliminary diagnosis and what would be your next step of management?
So this patient actually has a cerebral infarct. So a patient just postpartum and then having developed fever and then having cerebral infarct. For this kind of patient, we are very worried about the septic emboli being thrown to the brain. And this patient is young. It's not an elderly patient that we can simply treat this patient with aspirin and say this is a cerebrovascular accident and stroke. So in this patient, we need to do a three set of blood culture early in order to identify the organism, because infective endocarditis throwing septic emboli to the brain causing stroke is is the highly likely diagnosis. And being said that, because patient, the other thing that can causing a cardiac emboli to the brain will also be, we need to do an echocardiogram urgent, not only to look at vegetation, but also to look at the persistent foramen ovale, where some clot or emboli can go to the left side and thrown to the brain. The others differential that we shouldn't be missing to think broadly. Also, whether this patient is having a vasculitis in the brain caused by SLE, being a ladies, and then all the list of a young stroke we should be consider, like syphilis, to send a RPR test to screen for syphilis, and then whether this patient has a congenital protein S, protein C deficiency, antithrombin 3 deficiency, and so on.
Okay, that was a very holistic approach, Dr. Leong. Right. So the patient was admitted into ICU, and she had some blood investigation taken, and part of it is definitely like what you mentioned and the panelists mentioned, blood culture and sensitivity. So her blood sample taken from 3 different sites came back as gram-positive cocci in clusters, and even her urine culture came back as Staphylococcus aureus. Now, at this point of time, with the CT brain findings and the blood investigation, what will be your preliminary diagnosis and what is your next approach?
In this patient, we will be narrowed down to infective endocarditis with Staphylococcus aureus, which is a very, very likely diagnosis, because Staphylococcus aureus is not a common urinary pathogen. Common urinary pathogen should be E. coli. So this patient, why he got urine culture Staphylococcus aureus, is more likely to be hematogenous spread from the bloodstream to the kidney and then causing Staph aureus there. So in this case, I will say that we should start antibiotic, cloxacillin, as early as possible and look hard for infective endocarditis and get a urgent echocardiogram done.
Okay.
A simple practical question, Dr. Leong. Why 3 sites? Why specifically the magic number 3?
Yeah, because in this scenario, endocarditis is very likely, and it's recommendation to do 3 sets of culture before we start antibiotic, because we do not want to miss the organism. Sometimes you get first 2 sets, and then when there is bacteria is high load, the load viral bacterial load is not high enough, we get negative, and then after we start antibiotic, we got no chance of isolating the organism anymore. Yeah.
Right. So, Dr. Leong, is it 3 different sites or just 3 sets at any site?
3 sets, I will say, as a different site, right, and then left cubicle fossa, and maybe you just do it 1 hour apart,
Right.
rather than every other day, because we also, on one hand, we want to do 3 set culture before antibiotic. On the other hand, we do not want to delay the initiation of antibiotic as well.
Okay. That's very clear, Dr. Leong.
Yeah.
I think Dr. Geetha mentioned, Dr. Leong mentioned about echocardiogram.
Yeah.
Yeah. So, Dr. Geetha, can I ask, what are the indications for to perform an echocardiogram for patient who comes in with fever?
So I think here in this particular session, patient presented with cerebral infarct, and the CT scan shows evidence that it's possible a cardioembolic event. And usually the neurologist will be able to tell you, or even the radiologist will be able to tell you. So when you're looking at someone like that, leave the fever out of the picture first. So when you have a cardioembolic suspicion, you have to do the echo. One, of course, to rule out any clots within the heart, rule out any abnormal, like Leong mentioned, PFO, and it's a pregnant post-delivery risk of DVT is there, so she may have a thromboembolic event if you have a PFO and a paradoxical embolus. So you look at structural lesions that may actually contribute towards this cardioembolic. And also, I would also worry about an arrhythmic cause. So, sometimes you have to think about doing a halter or going back into the history to see whether the patient has any palpitations or anything. So you want to rule out the 3 common cardioembolic causes. And in this situation, because of a sepsis, of course, infective endocarditis is very high on the list. So you're looking for vegetations. So that would be something that would already trigger this patient to having an echo. But all in all, you're now seeing a patient who is sepsis, Staph aureus that also. No evidence of where the source of the sepsis is, not as if she's got long lines or anything. And then she's also had a thromboembolic event. I think that by itself is a real indication that this patient, you really need to look hard for a infective endocarditis. So therefore, there is adequate evidence that you need to do echo here. But I do appreciate that assessment of echo and getting access to echo is not easily available for many. So Leong, there's always this controversy about, this patient's got Staph aureus, she's post-delivery. Is it a septicemia versus is it infective endocarditis, and hence you need to do an echo quickly? So here, of course, this patient has very clear criteria that is probably an infective endocarditis, but I'm just talking in general. Staph aureus is quite common, and you have this septicemia. So how do you decide whether you want to treat first, and then when do you accelerate to doing an echo?
Yeah, as Dr. Geetha mentioned rightly, in a public hospital, to get an echocardiogram is not easy, because if everybody got a Staphylococcus aureus and then we ask for echo, the echo may not be able to cope. So we will say that for all patients with Staphylococcus aureus or any fungal candida, we should do a blood culture 3 days apart after your initiation of antibiotic. By day 3 culture shouldn't be positive anymore if this is an uncomplicated Staphylococcus aureus bacteremia. So if your blood culture at day 3 is still persistently positive, we should push hard to look for an echocardiogram, because the Staphylococcus aureus and fungal are very pathogenic. They highly get endocarditis that can even cause epidural abscess and all that. So we should look hard where is the source if day 3 blood culture is still positive.
The magic word to get an echo, she's pregnant.
Yeah.
Or she's still within the postpartum period.
Yeah.
Right, okay, thank you, Dr. Leong. So now let's have a look at some images which shows her echo finding. Yeah, so on the left side, the echo actually shows that there, if you can see, there is a small vegetation at the mitral valve. Yeah, then the next one on the left side as well, it is clearly shown that there is a mitral valve regurgitation. Okay, then the one on the right here shows vegetation on the mitral valve again. Right. Okay, so with all this echo finding, Dr. Geetha, I think a lot of us, many of us who are non-cardiac trained, we are actually clueless about what to look for in an echocardiogram when it comes to infective endocarditis. Do you have some tip for us?
So I think the first most important point I want to stress is not finding a vegetation does not rule out infective endocarditis. So in a situation where if you've got very strong clinical evidence of possible infective endocarditis, or your high level of suspicion, or especially in high-risk patients, then just because you don't find a vegetation on your echo, it does not rule out infective endocarditis. So you have to remember that. And then when you assess these patients on the echo, the first thing you want to do is look for structural lesions. So this is a patient who's never had any cardiac diagnosis before. So you want to look for any structural abnormalities in the heart, whether there's any valve lesions, any congenital defects, and again, like I say, looking for clots and all. The second thing you want to do is then you want to look at the functional status of the valves. So if a patient has got a severe MR, who's never had a cardiac problem before, and now you suddenly see a severe MR or severe aortic regurgitation, then that should trigger you that something has happened. So the functional status of the valve. And if you have prosthetic valves, then you want to look and see whether the prosthetic valve is functioning normally, or is there dehiscence. And then, of course, you also want to look at the hemodynamics function of the heart, whether there's severe MR, you might have ventricular dysfunction, LV function may be down, you may have pericardial effusion. And then you zoom in to focus on the vegetation, if you find a vegetation, and of course size of the vegetation, and generally you need to take 1 or 2 measurements and document that, because you want to monitor whether this vegetation is getting bigger or not in time. You also want to really look at the valve per se, whether there's perforation, whether there's any, sometimes the chordae rupture, then you get a flail leaflet, no severe MR in the situation. You also want to, if you have prosthetic material, then you really need to look hard, especially if it's a prosthetic valve. You really want to look for perivalvular involvement. And if you have an aortic valve infective endocarditis, you also can have perivalvular abscess and all. So you want to look for those things. So first you look at the valve, the function, and then you want to look at complications. And of course you want to assess the patient's ventricular function and the severity of the lesion.
Okay, right. So the echo finding for this patient, the ejection fraction is 55%. She has a good left ventricular contraction. The LA is a bit dilated. The left ventricle and right ventricle are both normal. There was thickened mitral valve with severe mitral regurgitation. There was pericardial effusion seen. And there was a mass at the anterior mitral valve leaflet, suggests vegetation, but the size is small. So looking at this echo finding, Dr. Geetha, do you think we can summarize and say that this is infective endocarditis?
I think, again, I must stress, go with clinical patients, general investigations. Here the patient has sepsis and then looking at the echo. The reason why I'm saying that, say if you see a patient who has got no infective parameters at all, and then the patient doesn't have any evidence to suggest an ongoing sepsis, and then you see this small size, what looks like a vegetation, you know that differential diagnosis, one of it is Littmann sac endocarditis in SLE. They can also have embolic events. So you have to really take everything into context. So in this patient, definitely this is IE. I don't think there's any contradiction to this. The question is how severe. So the mitral valve is severe, and then so you're concerned about the hemodynamic effect of this MR, and then pericardial effusion. If I see pericardial effusion, my concerns will be heart failure, so I want to make sure that the patient's heart failure is well controlled. The other thing is the sepsis itself. Is it a pan-septicemia, pan-carditis going on, you know? So whether there's pericarditis, septic pericarditis, and whether that's also causing the inflammation and pericardial effusion. And another thing, because this patient, we don't know what is the underlying cause of her valve, underlying structural valve lesion. She probably has some MR. Maybe it's congenital mitral valve prolapse. Maybe she's got somebody who's got rheumatic heart disease before and was subclinical and she didn't realize. So in a patient, when you have history of rheumatic heart fever before, you also have to think about whether there's some acute on chronic carditis that's going on, because they also can have some pericardial effusion. So you have to think about all those things. But I think here in this situation, most likely it's due to heart failure.
Okay, right. I remember those days when we were in medical school. We were taught about Duke's criteria in the diagnosis of infective endocarditis. Has it changed, or is there any update on it, Dr. Geetha or Dr. Leong?
Okay, so I'll pass over to Leong later, but I just want to say something about Duke's criteria in today's terms. So this patient, you're very lucky, or rather we are very lucky. She fulfills the two major criteria up front. She's got a positive culture and she's got a finding on her echo that is a vegetation. But many a times today we find patients that do not fulfill the typical definitive criteria for Dukes. They either don't have two major criteria or they don't fulfill all the minor criteria. So there's probable or possible IE. And I think that is where it becomes very important to add on other imaging. So say if you did the echo for this patient and you were uncertain whether this patient had IE or not, say there's no vegetations, then you would need to repeat the echo again after a week or accelerate to more advanced imaging like transesophageal echo. More so if you have patients who have got prosthetic material inside. And then you need to think about looking at other sites of potential embolic events. So now they have included, like if you do an MRA of the brain and you find silent infarcts, that's a minor criteria. So you can do a CT scan of the abdomen to look for splenic infarcts that might add on to give you some additional advantage. And then they talk about this PET scans and looking at this SPECT scans and all that, where you can do all these nuclear scans, so you can have hotspots, you see. So what do you think of that, Dr. Leong?
Thanks, Dr. Geetha. I just go by my routine practice is in a hospital, what is my view on Duke's criteria. We have many criteria nowadays in our medicine. We got Duke's criteria for endocarditis. Even SLE got their own criteria to diagnose. I sometimes find that all these criteria are quite strict, and sometimes we cannot be just say that we can rule out this is not an infective endocarditis. It doesn't fulfill all the criteria being written in the Duke's criteria. Because my frustration is, let's say if I have a patient persistently culture positive, let's say I do a blood culture 3 days later positive, despite that I'm giving IV cloxacillin 2 grams 4 hourly aggressively, make sure the patient in correct dosing and the nurse is giving it correctly, and yet I still persistently grow Staphylococcus aureus. I agree with Dr. Geetha. A lot of time I will start calling IJN or cardiologists to beg for a transesophageal echo because I couldn't find a source. or what I'm doing is, of course, I cannot argue that this is endocarditis because a lot of time we do not fulfill, then it's difficult to argue that this is endocarditis. So I will probably do a CT thorax abdomen, look for abscess elsewhere, whether he has epidural abscess on all that, and failing which I still will beg a cardiologist whether I can get a transesophageal echo or even go higher up a PET scan. Because we want to know where is the source.
I think if you look at the literature, Staph aureus bacteremia, if you cannot find the source of the infection and it's difficult to treat and recurrent infection, that itself is an indication to do an echo, and if not just transthoracic, maybe a transesophageal echo to look for possible infective endocarditis.
Yeah.
I would just like to add a little bit about clinical acumen and looking for the patient's progress. Please correct me if I'm wrong, but I think the person who first described infective endocarditis was William Osler himself. How often do you see the clinical signs, the rot spot, the Osler's nodes? I think we hardly see them these days. But I think if the patient is not getting better, it's always good to take the history again, revisit again. Don't be too strict with the criteria, but it's important to bring in the team and reassess why and what are we missing.
And sometimes accelerate investigations, like Leong said. The other thing is the cultures, because not all infections or organisms you can just get the culture. So you have this first, we already have culture negative, which is quite common today. And then you have the more resistant or fastidious organisms. So how would you recommend managing these cultures and accelerating to more advanced like serology or PCR that they talk about, right?
Yeah.
What do you think, Leong?
Yeah. In medicine, in laboratory investigation, I will talk on behalf of a microbiology part. There are a lot of advances nowadays. Serological test is good to do, but sometimes we may not be able to differentiate old or recent infection. Now they got a PCR test, molecular test. I'm yet to try and see whether in the future, if the patient has clinically very suspicious of infection, there are molecular tests like 16S RNA, whether we can use that to identify the germs or not.
Okay, I think just now Dr. Leong and Dr. Geetha both mentioned about a thoracic echocardiogram and transesophageal echocardiogram. When would be the indication for us to go ahead, go further and perform a transesophageal echocardiogram?
Okay, so TE is not easily available in most places, and especially for this patient, she's in WCH and IJN, and then you want to bring the probes over to do it. So it's there is that inconvenience. However, to me, TE is actually a very useful tool in diagnosing infective endocarditis when you have a patient where your transthoracic window is poor. A lot of times you have all these obese men with very thick chests and all that. So you have poor echo window, so you need to consider TE in this situation. And then if you do your transthoracic echo and you cannot find anything, but your level of suspicion is so high, and on top of that you have a very typical organism, then you want to accelerate to do TE. And then the other situation is like Leong said, all these very Staph aureus, fungal infections. You really want to consider doing a TE when your transthoracic doesn't give you additional info. And then, of course, your complex congenital and prosthetic heart patients. So anyone with a prosthetic valve, you need to do a TE because, or even conduits and all, because the sensitivity of a transthoracic echo here is only like about 50% average, whereas if you do a TE, it goes up to almost 80 to 90%. So in that situation, you have to do a TE. And then you also may consider doing your TE, say if your, you have some patients where you do a transthoracic echo and then you cannot see the paravalvular extension when there's complications and all that. So that's when you want to accelerate duty. So you have say aortic valve in endocarditis, and then you're looking very hard at transthoracic echo, but you cannot appreciate all this paravalvular extension, patients not getting better, deteriorating either from the sepsis point of view or from the cardiac point of view, then that's another indication. So whenever there's new complications or worsening. And of course, TE plays a big role when you're managing surgically intra-op.
Right, thank you, Dr. Geetha. Now let's go back to our patient. So from day 1 being admitted into AICU, now she is day 5. Unfortunately, she deteriorated. She required increasing ventilatory support, and she was started on some failure drugs, which includes furosemide, isodiol, bisoprolol. For a very brief moment, her condition improved, and she was able to wind down on oxygen, on nasal prong oxygen. So this case, after we have performed the transthoracic echocardiogram, she was referred to Dr. Leong, the ID team, and the cardiac team, and we have started her on antibiotics. Right. So, Dr. Leong, in this kind of case, what will be the choice of antibiotic when it comes to infective endocarditis?
Coming to the choice of antibiotic, the first line of choice for Staphylococcus aureus endocarditis, if it's sensitive, we still prefer and we highly recommend to use intravenous cloxacillin. Even though it's an old generation drug, a lot of misconception, people feel that vancomycin kills better, which is wrong. Vancomycin is actually less potent compared to cloxacillin. I need to remind everyone that don't look down on cloxacillin. It's still a very, very potent, more potent than vancomycin to treat simple, sensitive Staphylococcus aureus endocarditis, and the dosing will be 2 grams 4 hourly. Then the duration, it ranges where to see whether this is a right-sided or left-sided endocarditis. If it's right-sided, if it's fulfilled the criteria that I'm putting on the slide, we can actually give 2 weeks. If it's a left-sided, preferably we give 4 to 6 weeks. Vancomycin is not better than cloxacillin. In fact, it's less potent compared to cloxacillin. But unless the patient is got some allergy or he can't take cloxacillin, then we will go to the alternative. Either you can still use cefazolin or even then only we go for vancomycin. Yeah.
Right. Okay. So this patient has been started on antibiotic. What would be the red flags to watch out for? Dr. Geetha, Dr. Munis?
So I'm the obstetrician in the group and the least experienced with regards to infective endocarditis. But I think once we have initiated treatment, the principle is to monitor progression. Does the patient get better? Does the patient clinically get better? If the patient is improving, then I think there's no need to rock the boat. But if the patient develops a new sign or a new symptom, I think it's good to address that. And sometimes when consultants do rounds, now it's quite difficult to get a consultant to see a lady in the postnatal state. So I think any ill mother, irrespective of where she is, she has to be escalated appropriately. It's good to document what to look for, because I think these are the red flags on when to escalate, when to revisit, and when to call a team. So I think that's extremely important. Not just antibiotics, 6 weeks, TCA, 2 weeks later.
Okay. Dr. Geetha?
So I agree with Munis. Close surveillance, having some endpoints to review, or at least to call for expert opinion, and writing it down so that the person who's doing the rounds, the house officer, the medical officer, can identify this early. And some of the important things is, I think if you start antibiotics, as Leong said, you want to see the fever settling. If the fever is not settling and continuing to spike, that is a red flag. And then any new embolic event. So sometimes patients may have settled and then get a spike of fever, and then they might complain, maybe you might have a clear-cut neurological headache, or even lungs, sometimes they will say they start coughing, and then they got some pleuritic pain or abdominal pain. So any new embolic event. And then from the clinical point of view, she's got a cardiac problem. And then if she's getting worse in terms of a heart failure, that's something you want to look out for. And for those patients with aortic valve involvement, if there is a new onset of arrhythmias, you also want, especially heart block, that's something that you want to look out for. The thing is a new onset murmur. So you're listening to the patient clinically, and then suddenly you hear a new murmur. That's something else that you want to do. So all this, when you have this, you want to quickly request for another echo. You want to do another maybe septic workup because she's in hospital. She could pick up another infection. Maybe your antibiotics is inadequate. Maybe the line, because this is Cloxa, you have to give every 4 hourly. It's very toxic to the veins. So you have to have good lines for this patient. Make sure the dose of the antibiotics is appropriate. And I want to ask Leong, is there any resistance to Cloxa? Do we have to check MIC and all like the patients with strep? And then review that also? Because that's another important thing, right? The dose appropriate and the sensitivity.
Yeah, for strep, you need to look at the MIC. Agree there is sensitive, intermediate, and resistant. But for staph, it's either sensitive or resistant. Right. So if it's resistant, the microbiologist will report as a MRSA. So if it's MSSA, it means that it's still very sensitive to cloxacillin.
So the other issue we face is that when the patient has got very bad infection and then there is extra cardiac manifestations, like in the lung or soft tissue like liver or spleen and all, do we have to add on like rifampicin or anything else to this group or not?
Not really. Yeah, no. Not really. This is what very good Dr. Geetha asking this question because this is a challenge for an IT physician because whenever a patient not responding, when there is a persistent fever or even persistent culture positive, so a lot of us will be whether is there any role of adding on another agent, a second agent? Traditionally, older guideline you can see we put cloxacillin and gentamicin, but the newer guideline is already kicked out the aminoglycoside because there is a lot of studies shown that adding on aminoglycoside on top of cloxacillin, it doesn't show that it's more effective. It probably will reduce recurrence rate, but it's not more effective than cloxacillin alone for a native valve endocarditis. Unless this is a prosthetic valve endocarditis, they add on the literature recommendation, add on rifampicin and all that is because of the biofilm formed in the prosthetic heart valve. Okay. If this is a native valve, a lot of literature shown that there is no necessity to add on aminoglycoside. So I have to say that we need to be evidence-based. So if the patient not responding, then we have to look hard for others. I will push cardiologists to look for transesophageal echo, whether he has a form of perivalvular abscess and all that, rather than adding on or changing antibiotic.
Or sometimes even a PET scan, to look, because sometimes you can't really appreciate some of this paravalvular involvement. If it's clear on the transesophageal echo, that's fine, but sometimes you need to accelerate and do a PET scan and look for hot spots, especially if the patient has already been on antibiotics for a while. I think the cutoff for us, like Leong said, 3 days not responding, so anything between 3 to 5 days, the patient is not getting better, something's not right.
Right. I think you guys are really just very good. So let's see what happens to our patient, yeah? Okay, so you are right. She deteriorated further. Her GCS dropped and she was intubated now. She developed decompensated heart failure now and non-oliguric acute kidney injury. She was started on inotrope and she had a pericardiosynthesis performed because the pericardial effusion was getting worse. She had a repeated blood CNS, which now grow a new bug here, which is a Burkholderia capacia. And we did a repeated CT brain and CT thorax, abdomen, and pelvis, show superimposed infection and multiple microemboli in the kidney, in the spleen, and in the liver. Okay, I think this is.
That's me lah. Yeah.
So I can see you are really frustrated. So for this kind of cases, you have tried first-line medical management, but patient still deteriorated. What do we do next?
Yeah, this is, I'll tell you, I'm managing this case as a this is where infectious disease clinicians feel very frustrated because on one hand, as Dr. Vicky has mentioned, that this patient already got not only septic emboli to the brain, he also got septic emboli to the spleen and all that. So in my heart, I'm thinking that I almost want to push him for, he probably already trained septic emboli, is already a clear indication for surgery. But unluckily, because the fever not settled, and IT physician always recommend to do a blood culture, so people do a blood culture. But it add on to my headache because the blood culture is not growing Staph aureus anymore. It grow a Bucholderia sebaceae.
Yeah.
Then people will ask me again, how long duration to treat for this Bucholderia sebaceae? Has this Bucholderia sebaceae also causing endocarditis? So if I chasing like that, I'll tell people will no end to it because and then next day you grow another organism. When is this patient able to go for surgery? Forever he will not be able to go for any intervention. So and when we look back, actually the Bucholderia sebaceae is also grow on the this patient got a PICC, a peripheral inserted central line for her cloxacillin. So we noticed that actually the central line is an issue. So I have no choice to treat the Bucholderia sebaceae on top of giving cloxacillin. So I have no choice to add on. I add on another regime, another antibiotic, not because I'm not confident that the cloxacillin is not working. The reason I add on is because he has a new line-related sepsis, which is Bucholderia sebaceae. So I'm adding on either I can add on a ceftazidime or Bactrim to treat the Bucholderia sebaceae, and I'm asking them to remove the remove the PICC. Then and that is what happened in our patient. Yeah.
Delay surgery again.
Right.
Yeah.
So
Yeah. That's where I got headache, and I called Dr. Munis to join me because I don't want to have a postpartum mortality meeting later. So to brainstorm how am I going to move forward to do better for these patients.
right, okay. So you mentioned about this is a clear-cut indication for surgery. So let's talk about surgical management, Dr. Geetha. What are the indications for surgical management for infective endocarditis?
So basically, let's talk about vegetation first. If the vegetation size is more than 10 mm on the left side and 20 mm on the right side, that means size, that is an indication. Then you want to talk about the perivalvular abscess, any infective endocarditis patients where there is complications, pseudoaneurysm, fistulous development, heart block, that's another indication. Of course, from the infection point of view, if you are already treating the patient optimal antibiotics but you're unable to clear the sepsis and the patient keeps having recurrent ongoing infection, so you need to clear that. And if the patient has hemodynamic instability because of either the valve problems or the sudden acute, sometimes they have acute rupture of the valve and then you go into acute decompensated heart failure. There's only so much you can do in terms of medical management. So that is, once you stabilize the patient, you need to consider surgery in this situation. And then they also talk about the type of organism. If you have a patient with fungal infective endocarditis, very difficult to clear, and these are the type of patients that you may consider, that need to be considered for surgery early.
Right, but let's say like this patient, the echocardiogram earlier actually showed the mass was actually really small. Would you take that into consideration as well?
So The other thing I didn't mention is recurrent septic embolization despite treatment. So when you talk about size of the mass, does it matter? Yes, of course, I mentioned 10 mm is a cutoff of left side and 20 mm on the right. But in this particular situation, the patient already had recurrent septic embolization. So the size of the vegetation here is not, you shouldn't just use that as the one absolute value to look for, because probably the vegetation was large and already has thrown embolus elsewhere, so maybe now what you're seeing is just residual vegetation. So the size, you have to take it with a pinch of salt, and you look at the whole picture.
Right. We always speak about retrospective view.
Yes,
yeah?
I understand
So,
now. So
so
it's
do
very
you-
obvious in this
do you
patient.
think that, in this patient, if we would have, decide or consider surgery earlier, would it have
So
make any difference?
the point where she presented with Staph aureus with history of already has a septic embolization, and then she deteriorated, right? That was the first point where before the second onset of sepsis, she already deteriorated. At that point, ideally we should have called for an MDT, and discussion should have been made about surgical intervention at that point. I think she already had enough indication for considering surgery at that point.
Right.
But one thing is guidelines, one thing is theory, the other thing is the practical implementation of a lot of this. You know, surgery has got its risk in pregnant and this is a non-pregnant woman, but in pregnancy it has its risk. In a sick patient, it also has its risk. Somebody with active infection. So we really have to have an MDT. Everybody has to sit down together and plan how we're going to address this patient.
Right. Dr. Munis, as an obstetrician, where do you think an obstetrician fit in this context?
So I think we did discuss this in many conferences. There's only one thing that I've learned in obstetric medicine is patient ownership. I think when a patient is ill in ICU, having multidisciplinary care, there's always an argument of who the primary team is. I think we need to be responsible for our patients. We need to own our patients. And I often feel, I may be wrong or biased, but I often feel that the obstetrician should be the leader. She's in the postpartum state. She's got a confirmed infective endocarditis. We have got the ID consultant in the hospital to care for her. We have got the experts in infective endocarditis managing her. But the patient is still in the postnatal state. I am the leader. So I think we need to revisit and call the team. Anyone can be the primary team, but I often believe there should be one leader. Perhaps not a leader, perhaps not the driver, but perhaps the master of the symphony. So what happened? I thought we should call the team. We should learn to work together. It is not wrong to call for help. In fact, the number of times I call Dr. Leong and Dr. Geetha in a week is far more than the number of times I call an obstetrician. So I think it's time for an MDT. The multidisciplinary care, or people now call it interdisciplinary care, has been proven scientifically to elevate care. And we bring a group of people together, the care seems to be better. And when you work as a team and discuss, you'll be surprised that we don't learn from each other, but we also do things that we think in our own silos were not possible. So I think the obstetrician is definitely the leader, be it pre-pregnancy, be it antenatally, or be it postpartum, or be it inter-pregnancy as well. So multidisciplinary team, I think Dr. Geetha mentioned it. Now, who's the team involved? Sometimes getting too big of a team, you may lose focus and you may not achieve your objectives. My objective here was clear. This patient needed surgery. So we brought in the cardiothoracic surgeons. My objective was clear. This is a high-risk patient. We need the intensivist. The cardiologists would have concerns, so we brought in the neurologist, the consultant neurologist. Of course, the cardiologists, the infective disease specialists, in fact, even the microbiologists. In obstetrics, the more people you call, the more burden you share, seems to be the norm. And that's what we did.
Right.
I think today they talk about infective endocarditis team. Here there's of course a pregnant patient who's under the obstetrician, but generally the infective endocarditis team includes the cardiologist, the ID physician, the cardiothoracic surgeon, and then plus minus the neurologist wherever necessary. So they already talk about this team, and then you can add on others accordingly.
Right. Okay. I hope we have more people joining the infective endocarditis team. Yeah, and everyone is aware of that team, so we know exactly who to call.
So,
Yeah.
yeah, so because once you develop this team, then the team takes on all these high-risk cases. So your experience also builds, your confidence also builds. So that helps. Because a lot of times you're just doing one case, it can be quite scary actually and difficult to handle. So as your confidence builds, as you share the burden, like Munis said, your intensivists and all, everybody builds the confidence together. And then imaging specialists is something else that is important in the IE team.
I would like to add on one important person in the interdisciplinary team is the patient. So let's not forget what is the patient's perception. What is the family member's support? Often 5 doctors making a decision in a round table does not mean that is what is the best for the patient. So I think we should also include what the patient feels.
Yeah, true.
Right. So an MDT was called for and was attended by the cardiothoracic surgeon, the consultant cardiologist, ID consultant, cardio-intensivist, cardio-anesthetist, neuromedical consultant, as what Dr. Geetha mentioned, the neurosurgeon, nephrologist, radiologist, maternal medicine consultant. So decision was made for surgery. Okay. So when it comes to surgery, Dr. Geetha, I think what else do we need to prep the patient for? Yeah.
So you want to ensure good outcomes in this patient. So the first thing is to make sure the clinical status of the patient prior to surgery is optimal. So heart failure management, control of the infection to the best possible, and then look for things like anemia, correct anemia, also renal, liver, all those functions should be optimal as best as you can. I'm sure there's always limitations, but you want to get that all to an optimal state. And then you also want to repeat your imaging, maybe your echo, because you need to see what's the status of the patient prior to send the patient for surgery, functional status of the patient in terms of ventricular function. So you want to repeat some of these imaging modalities. And then you need to look at extra cardiac manifestations. So for this patient, one of the main concerns, of course, the surgeons would have the neurological implication here. And no doubt these patients, we have seen just on the CT scan, or was it MRI? CT scan, that the patient had an infarct. We are always concerned about mycotic aneurysm, and you're putting this patient on a bypass circuit with anticoagulation. So if there is a mycotic aneurysm, the patient's at risk of bleeding, and you go through everything and only have a patient that becomes morbid because of an intracranial bleed post-op. So therefore, our recommendation is anyone who has got a left-sided vegetation, we are quite aggressive to do a proper scan. So sometimes it's a 4-vessel angio, sometimes it's MRA, to rule out any silent mycotic aneurysm. And if there is, and I think they use 1 cm as their cutoff, interventions has to be done to address that first. That's why the neuroradiologist has come on board here. And then the next thing that you want to review is anticoagulation. Here in this patient, thankfully, it's just prophylactic anticoagulation, so you can just stop the Clexane and proceed. But for many of these patients, sometimes they may have intracranial bleed, or they may have a prosthetic valve where they may already be on anticoagulation, so you want to manage the anticoagulation well. If you're lucky, if you've got a hematologist who supports you, but most of the time it's managed by the cardiologist and with the neurosurgeon. So the timing that they've given for anyone who is who has an intracranial bleed, or with you have to stop all anticoagulation for at least 4 weeks before you consider recommencing the anticoagulation. If you're thinking of surgery, again, you're looking at reviewing after 2 weeks plus minus 4 weeks. So you need to, that's why the MDT is very important, to decide the best timing if the patient has an intracranial bleed, or if the patient has a very massive infarct. Here the patient doesn't have just micro or small infarcts, water. But if the patient has a massive ischemia, you worry about the peri-ischemic region. When you bleed, when you put the patient on bypass, they may have bleeding. So so that's important. So you need to think about bleeding. So these are some of the things that you want to prep the patient for. And don't forget oral hygiene. So definitely have to see a dentist and review her oral hygiene, because you're going in for surgery, you may put in a prosthetic valve. The last thing you want to do is have another infection on that prosthetic valve. So these are some of the things you look for prior to sending the patient for op.
Okay, thank you,
There's
Dr.
one more thing I want to say. Sorry. The intensivists, and it becomes very important because they look at the patient's status, and this patient is very ill. So you want to plan bringing the patient down to the ICU, cardiac ICU, maybe putting in some inotrope support, prep the patient up, maybe optimizing the heart failure before sending the patient for surgery. That's another thing. Sometimes you bring them and prepare the patient for op.
Okay, right. So after the MDT, this patient was transferred to the cardiac center, and she had a transesophageal echocardiogram and MRA done prior to her valve replacement surgery. So her transesophageal echocardiogram shows a thickening of anterior mitral valve leaflet with prolapse of flail of A2 scallop, perforation causing severe mitral regurgitation, appear to have 2 regurgitation jets. From the prolapsed scallop in posterior direction, and there is a perforation of A2 at the anterior mitral valve leaflet thickening. So there is all the findings also suggest that there is residual vegetation. So she went on ahead and had a surgery done. She was transferred to the cardiac center on day 30, and on day 31, the mitral valve replacement surgery was performed. So mitral valve replacement surgery performed. She also had a tracheostomy performed for prolonged ventilation. Subsequently, she underwent rehabilitation and she recovered well. So I think this is when Dr. Leong feel such a relief. She weaned off oxygen, changed to Shiley's tube, and she was discharged after 14 weeks of admission. She was able to transfer independently to wheelchair and ambulate with walking frame.
I think it was not a relief, but I think it is a satisfaction. We often quote, it takes a village to save a mother's life. And I think all of us coming together, I remember not one, not two, but multiple MDTs for the same patient. And it's satisfying to see that Dr. Leong's frustration turned into the patient living today. And we wanted her to walk out of the hospital, but I believe we'll achieve that one day.
I think the point about the patient is important. So after all this, at the end of the day, is to ensure that the patient is well, and also continuity of care. So I'm looking at this and I'm hoping that this patient is under cardiac follow-up, and there's someone now responsible for this patient's follow-up in terms of the valve, because she got a prosthetic mechanical valve, right? They put in. Yeah. So the warfarin care, the dental care, the review, because her journey is probably just beginning, I think, for me as a cardiologist. So that's very important. Just ensure she has got, and contraception and planned pregnancy. You know, she might come back pregnant with warfarin on board, and I think, Munis, you still can't let go of this patient. So preconception counseling, planned pregnancy, very important here.
Yeah, thank you, Dr. Geetha. You are really very holistic and very thorough. So let's turn the picture around. What if this patient is actually not a postpartum patient, but she presents at 27 weeks of pregnancy? Will the management be the same? Dr. Munis, will you consider the role of delivery? When would you deliver, and how would you, what is the mode of delivery?
So, as an obstetrician, we really find uncomfortable seeing pregnant mothers at 22, 23, 24, 25, 26. I think although our principle is mother's life always first, I think as obstetricians, we should also advocate that it's also our responsible to try to save both lives, if possible. So I would call for an MDT. I would call for all the known experts that I know. And I think the Zoom platform has opened up a lot of channels. We can even consult cardiologists from different centers if you don't have an in-house cardiologist. Although people often call us as the person who delivers the baby, my first question is, how long can we prolong this pregnancy? Not compromising on her health, but how can we make her better in this pregnancy? That will be my first thought. So antibiotics, how long? What is the dose? What's the medications? Surgery, I'm open for surgery. If an obstetrician can do a caesarean section on an ill mother, why can't a surgeon do a similar high-risk surgery in an ill mother as well? And those will be my thoughts, because I'm responsible not just for her, but also for her baby as well.
Okay, when it comes to antibiotics and duration of antibiotics in pregnancy, Dr. Leong, will there be any different? Will you change the antibiotic or the duration of antibiotic if she's pregnant?
Okay, I will put few scenario. Certain scenario comfort easy. If this is a similar patient, it happened at 27 weeks, it's also my headache. It's real headache because this patient clearly needs surgery. As Dr. Munis mentioned, because I know in my heart that this patient, if I stop the antibiotic, there is a very high chance of relapse because the vegetation is still there, you've got septic emboli elsewhere. I will pray hard that if I see a patient that without this complication, and if let's say not in our scenario, a more simple patient, I will look at Dr. Munis and ask when are you going to deliver? Because the surgeon may not, a lot of time I feel that surgeon will prefer me to complete the antibiotic, even though we have been discussed in the guideline, it may not be necessary to complete the antibiotic before we do any surgical intervention. Go back to evidence-based, I will say that in the guideline, if the patient is straightforward, not as complicated as our scenario, the duration of antibiotic always 4 to 6 weeks. If the patient still far, 27 weeks, is still far from any surgical intervention, I cannot just simply defensive and prolong the antibiotic until it delivered or surgical intervention. I will stop the antibiotic at 4 to 6 weeks and monitor, ask the patient, pray hard, no relapse, and then wait for the delivery and surgery. So that is a recommendation. But in this one, we have to be case-by-case basis and closely monitor.
I would like to highlight one important fact from the UK Embrace report that comes out strongly about why mothers with medical diseases die. The tagline is, we should manage pregnant mothers just the same as non-pregnant mothers, unless there's a strong reason not to. So I would ask them the same question. If she's not pregnant, what would you do? And I'll do the same, if it's within the safety margins of her.
So it's interesting because when you look at the literature, especially the more recent literature about surgery in pregnancy, they clearly state that the outcome, maternal outcome of doing surgery in pregnancy, cardiac surgery in pregnancy, is similar between the pregnant and non-pregnant women because we're so advanced today. However, the fetal outcomes are still not optimal. So there's still significant fetal morbidity and mortality. So a lot of times the concern is about losing the baby. It's not just the mother. And the general thought is that deliver baby first and then do the cardiac surgery. So you have, at least you've got the baby out and then you go ahead and deal with the mother. And this deliver baby becomes a concern with preterm, like this one, 27 weeks. So correct me, Munis, but from what I understand, it's best after 29 weeks in terms of good prenatal, preterm outcomes. maybe 27 weeks. If it's 27 weeks, you want to try and push it to 29 weeks, we might try and consider we can stabilize the mother and try and push the baby to 29 weeks and then deliver first and then worry about the mother. Of course, post-delivery, there's whole effect of the hemodynamics on the mother's cardiac status, so it has to be done in an expert center with intensive care monitoring and all. No? But the aim is always to try and deliver the baby. So you'll have to tell us when is the cut-off. But in the earlier gestations, it becomes a problem because you know that you can't deliver the baby, and there's high risk of fetal loss and fetal morbidity and premature labor. So then the issue will be, how do we best manage in an acute situation where the mother's decompensated dissection of the aorta, for example, or decompensated heart failure, and you know that the mother, you don't address the mother, you're going to lose the baby anyway. So then all these bypass techniques. So again, MDT, everybody has to sit down and really have to ensure few important things. I think the bypass, management of the bypass to make sure there's continuous perfusion, the blood pressure of the mother is maintained, no acidosis, and then and close monitoring of the baby during the procedure and after the procedure is important.
I'd just like to add on to Dr. Geetha's gestation. So 34 weeks seems to be what people define as mild prematurity, where most tertiary hospitals in Malaysia has got good outcomes. At 28 weeks, the survival may be 70%, but the complications can be significant. So it is always difficult to make such decisions. I think it's a balanced decision between the neonatologist, the obstetrician, the cardiologist. We just need to work as a team, counsel, but I think in such complex situations, the patient should be making the decision.
Right. Okay. Thank you for a thorough discussion. I think we had a very interesting case here and with very interesting and informative discussion here, right? So I would summarize from our case, the two cases that we've discussed about. So SBE prophylaxis is no longer indicated for vaginal delivery. Routine antibiotic prophylaxis during caesarean section is sufficient to cover for infective endocarditis. Ampicillin and gentamicin is no longer the choice of antibiotics, although traditionally they were both used. Think of infective endocarditis in the presence of red flag signs and symptoms like what Dr. Geetha had mentioned earlier. Consider surgical intervention if the patient is not responding to medical management, like our case here. Surgical intervention is not contraindicated in pregnancy because, like what Dr. Geetha mentioned, the outcome for a pregnant lady and a non-pregnant population is the same. Right. So I think before we wrap up, do any of our panelists have anything to add on?
There are no questions from the...
so far, no.
Right. So
I think, there's one question here. It's not the question is not about SBE prophylaxis, but some of the medical officer actually ask. They sometimes see the cardiac patients being on tablet penicillin, oral penicillin, for those patients with chronic rheumatic heart disease. So it's not about SBE prophylaxis, but since it's also relevant, so what's your take in prescribing patient with oral penicillin?
I think that's a very good question because penicillin prophylaxis is recommended for patients who have rheumatic heart disease. So how do you decide? Actually, there are 4 groups. I just want to run through quickly. If the patient has got history of rheumatic fever, rheumatic evidence of that, and the patient has no cardiac involvement, then it is 5 years of penicillin prophylaxis or up to 21 years, whichever is the longer. If the patient has mild cardiac involvement, mild WAF lesions and all, then it is 10 years of penicillin prophylaxis or up to 21 years, whichever is the longer. Now, if the patient has moderate valvular involvement, whether it's moderate MS, MR, combination lesions, then the recommendation is 10 years of antibiotic prophylaxis, penicillin prophylaxis, up to 35 years, because it's been shown that you can get acute on chronic lesions up to 40 years of age. But if you have severe valve lesions, you've gone for surgery, you've got prosthetic valves, you've got severe MS, then again 10 years or up to 40 years, whichever is the longer. And then they also say that if it's a woman in the childbearing age group and is contemplating pregnancy, you may want to consider giving this antibiotic prophylaxis for a longer period. And for patients who are going for oral treatment, you know, you always ask, you're already on penicillin, do we need to give oral antibiotics? Leong, maybe you can add that, but they say that the 250 milligrams BD that we're giving, or the IM benzathine penicillin that we're giving, is not enough to cover the patient adequately for that oral intervention, especially if an invasive. So they add on the current oral antibiotics on top of the routine penicillin. And in selected group of patients where they really got very bad valve lesions, they have already had the prosthetic valves put in, you can also consider giving lifelong antibiotic prophylaxis based on the individual case.
Right. Thank you, Dr. Geetha. Right. I think we had a very wonderful discussion. Yep. Thank you, everyone, for tuning in. And to those who actually missed the discussion, don't worry. There is a recorded video which will be released later on Facebook and YouTube in the Mums channel. Right? So we thank Dr. Geetha, Dr. Leong, and Dr. Munis for joining us.
Thank you, Vicky.
Yep. And here is a guidelines that you can refer to if you are interested in an infective endocarditis, whether in pregnancy or out of pregnancy.
And for the rheumatic heart fever, I recommend the Australian guidelines, 2020 guidelines, very user-friendly and very comprehensive.
Okay, thank you. Bye-bye.
Thank you, Vicky.
Thank
Thank
you.
you, Leong, Munis. Thank you, everyone.